Thank you for that introduction, and more importantly, calling me for this particular meeting. And I've sort of learned a lot since morning already, and I hope to learn more by the time I go back home. I'm going to be slightly different from what has been done so far, and decided not to specifically only focus on diabetes and CKD, but broaden this discussion to the NCD primary care. Let me give you a little bit of a background for the Indian story, no conflicts of interest to declare. India has got multiple states or provinces, and health is what is called in the constitution, it's a state subject. So the individual provinces have the right to come up with their own models in terms and decide how to allocate their health budget for what activity. So that creates a little bit of sort of difficulty in coordinating across the countries. That's the first thing we have to remember. The second thing is that despite there being a structure available for the public health system, perhaps because it didn't perform very well, perhaps because it's not as convenient for a lot of people, a significant proportion of individuals actually seek private care, more so in urban India, less in rural India, but still, I would say about 30, let's say 2/3 private, 1/3 public. The issue with private health system is that it's not as clearly regulated or structured. And therefore, for today's presentation, what I'll try and do is give you a sense of how the public health system takes care of primary care, fully acknowledging the fact that that's only 1/3, and I'm not even speaking about the remaining 2/3. So it's a multi-tiered system. It's very clear. In terms of the structures, it's a very clear structure. There are frontline workers who are at the community level. They're called accredited social health activists. Their primary job was initially maternal and child health, but has now evolved into more work in the NCDs. In the rural areas, in every village, there'll be an entity called a sub-center, which is non-physician manned. So there are nurses or non-physician healthcare workers whose primary job, again, is screening for disease, in addition to their other work for health sanitation and maternal and child health. Above that is a primary health center, which is a first level where there is a physician who is manning that particular facility. And usually, I would say, at an average, one primary health center between 5 villages, which is all right if they're close to each other, but in a country which is geographically diverse, sometimes even the distance to travel to a primary health center can be disabling. Above that is the secondary health centers, which are either blocks. Blocks are entities which are administrative units under districts. So their population which they cater to would be about 100,000 people. And then there are district hospitals, and India has about 760 or 765 districts. And then on top of that are the tertiary cares, which are the medical college system. So it is hierarchical. It does give you a provision for saying, these are the activities which should be done at this level of care. These are the activities should be done at the upper level of care. These are the sort of patients who are best aligned to a particular level of care, and these are the ones which should be referred up. But in reality, that does not happen. People walk in where they find it convenient to, so it's more Brownian than purposive, which is a big problem as far as really structuring care is concerned. The other thing for non-communicable diseases in a system like ours is, which was built primarily for maternal and child health and communicable diseases, which are, especially the communicable diseases, are acute finite care, right? Whereas here we're looking at chronic care, and the continuum of care is really something which has not received the degree of attention which it should reach, which is critical for non-communicable diseases. Because, just managing somebody on one visit is really going to make absolutely no difference whatsoever. And therefore, it becomes critical to integrate interventions with or without technology across all levels of healthcare so that you can diagnose patients, more importantly, track patients and their journey, improve referral linkages. As I said, we've got structures which you can refer up and down, but that linkage and facilitation is required. And then, of course, most importantly, retain patients in care. I mean, just to give you a sense of the typical absence of continuum of care, It's usually said it's a rule of halves. And this is data abstracted from the last round of the National Family Health Survey, 1.6 million adult respondents. Diabetes prevalence, this is up till the age of 50 or 55, depending on whether you're a woman or a man. So 6.5%, of which only 3/4 were diagnosed, of which only 60% were taking treatment, and of which only about 2/3 were having any degree of control. So you can see it really keeps dropping down, and it's not helpful at all, because unless you control diabetes and control hypertension, you will miss out on a significant proportion of causes of chronic kidney disease. So in 2010, the government then decided to create what was then called, till about a couple of months ago, the National Program for the Prevention and Control of Cancer, Diabetes, CVD, and Stroke. It's just a very long name. But importantly, it was decided that there should be opportunistic screening for 5 entities. And those 5 entities were diabetes, hypertension, and 3 cancers, which are common to our part of the world, which are breast and cervix amongst women, and cancer of the oral cavity because of chewing of tobacco and other things. So those 3, and diabetes and hypertension. And that was the first time this was really instituted in a particular fashion. Now this is how things have evolved. Let me just check if I've got, is that likely to give me a pointer, or am I looking at the wrong way? No, okay. Okay, so this was how it started in about 2010. Eventually it was then integrated into the National Health Mission in 2013-14, and opportunistic screening started. The population-based screening for this, then as I mentioned, the frontline workers started doing population-based screening in the community for people above the age of 30 years in 2016. And then we developed a slightly different national health policy and created what is now being referred to as a national NCD system. And then it further evolved into something which is called Ayushman Bharat. Ayushman in local language means may you live long. So basically, it's really giving you a sense of health and wellness in that sense. And very recently, trying to get a digital framework, so it's the Ayushman Bharat digital mission. So moving and broadening the framework from verticals, which are restricted to acute finite care and communicable disease and maternal child health, broadening that to get non-communicable diseases into that, establishing a national health program in which that would be an integral, horizontal assimilation, the new scheme of Ayushman Bharat, which is working towards universal healthcare and medical insurance, and then digitizing. So that's where it is. So really, this was a shift from selective healthcare to comprehensive primary healthcare, expanding a range of services. And if you remember the structure that I told you, the sub-centers and the primary health centers, there is a move to try and create, to convert these into what are now called health and wellness centers. So it's not just a health center, but it's also a wellness center. 150,000 of these have already been established. And increasingly, the sub-centers and primary health centers will transition to this entity. And as I said, most recently, a transition from paper-based software to digital record keeping. And this is the expansion. So again, the work package 7 for these health and wellness centers is screening, prevention, control, and management of non-communicable diseases on the whole. Right, this I've already spoken to you. And again, without going into the details, it's important to understand that there are finite activities which are given, and screening for diabetes and hypertension starts at the sub-center, which is, as I said, the non-physician manned entity, which is at every village. And if you hit a certain threshold, you are then referred up to the primary health center for confirmation of diagnosis and initiation of treatment. In India, unlike the UK, I assume, prescriptions can be done only by certified physicians. So prescriptive powers are not given to non-physician healthcare workers. So going to that primary health center is critical. Dispensing can be done lower down, but prescribing cannot be done lower down in the health system. And the entity of chronic kidney disease first finds mention at the primary health center or the urban primary health centers, and therein there are provision for that screening. This is a very, very new concept, and I'm not sure how how much of it has been incorporated till now. And then it keeps going on. So you keep adding activities all the way up. And the other thing which has now been introduced is by creating a national telemedicine platform, and that is now operational at the level of the secondary care institutions. It's important again to understand that India had no telemedicine practice guidelines, which meant people did whatever they wanted to do. And the absence of those guidelines, you could have situations which are not defendable by under normal circumstances. These brought out actually a month before we went into lockdown for COVID, fortuitously. And so a lot of transitioning into telepractice happened then, and fortunately it's now become an increasing part, not yet still significant, but an increasing part of this whole pathway of care. Right. So I'm now going to take you through two sort of predominantly one, because this is the work we were involved in, just to show how work at an academic institution can contribute towards policy making. I heard a question about stakeholders being involved, and I share that concern about too many stakeholders, sometimes difficult to manage, and sometimes you've got to do what you've got to do. But eventually it's the government which incorporates it, so keeping them in the loop is not such a bad idea after all. So as I mentioned, that what we've been working on all this while has been a combination of task sharing. So task sharing really refers to when in the apps, when even if there's a physician on site, some of the responsibilities of that physician are being delegated to non-physician healthcare providers so that they can do the specifics. So it's like a Super 6 variant for primary care, that you don't really need the doctor to do everything. They can be done, offloaded by other people. And the second part was technology, when we started working on creating electronic health records and clinical decision support software. So these were management prompts to assist physicians, fully recognizing that for a physician at a primary care health institution to manage tuberculosis, diarrhea, pneumonia, vaccinations, everything, and remember guidelines. I'm sure they're spectacular guidelines, we've just heard earlier this morning, but it's very difficult to keep on top of everything, especially if you're at the primary care level. So this is really the story of what we've done, and I'll take you down some of these steps. But we started with work at tertiary care, and essentially started saying the following. In people with diabetes, we know clearly what are the targets for control, whether it's glucose, blood pressure, or lipids. We have medication to address all those targets, but we do a tremendously bad job in meeting those targets. If you flip that around to randomized controlled trials, which are heavily resourced, you will find, Sophia will possibly validate that point, that if you looked at a study called ADVANCE, which had multiple regions, places like India, which traditionally don't do well in routine care practices, perhaps reach the same level of control as Northern Europe and Australia. So basically, if you're resourced and structured, you can achieve it. Obviously, that's too much money to be put into routine care, but that's what prompted us into creating this entity of an electronic health record, clinical decision support, and a non-physician health care provider to do that. From there on, we went to expand this into secondary care, primary care, looked at multiple other things. So we started with diabetes and CVD risk, big hypertension, lipids, and including collaborative care for depression. Fortunately, the government took attention, and 2 states of the country, small nonetheless, decided that this is a model which they'll use for their secondary care publicly funded institutions. So this became standard of care in that. And then we went on to a study which we're currently doing, which is encouraging, which said that, listen, there's no point doing something at primary, something at secondary, something at tertiary. Do a model which is a continuum across everything, because people will walk in where they want to walk in. And you need to ensure that you can't stop it. In India, you can't stop people doing what they want to do. You just need to nudge them to where they should be, right? So if they're adequately if they can be adequately managed for primary care, even if they walk up to tertiary care, just gently nudge them down so that they reach primary care, and then they stay at primary care. So both up and down referrals, and therefore we created this model which is currently being tested. And concurrently, the WHO, which has something called the PEN package, which is the package for essential NCD cares in Maldives, the WHO CRO asked us to convert that based on our digitization program, and that is currently operational in the Maldives. So this is really what we ended up doing, which is now hopefully getting incorporated as we go along. And first, that this is a usual flow in a clinic in India, that somebody will come to the clinic, they'll get registered, somebody will do their labs and vital signs, physician is going to see them and then send them off with a prescription to say, come back after 3 months or 6 months or whatever it is with these investigations. Whether they take their medication, whether they ever come back, nobody knows. So we flip that around to say that instead of the physician being the fulcrum of care, in that same clinic, whether private or public, there will be a non-physician healthcare provider whom we call a care coordinator, who receives the patient, does all the triaging, puts the data into the electronic health record, gets the management support prompts through the clinical decision supported software, and then trots off to the physician with the patient and says, this is a triage patient for your care. This is what the software is telling us to do. The physician, of course, has the privilege and luxury to say, to hell with your computer, I'll do what I want to do. But since this was a randomized control trial, the only request we made was, do what you want to do, but if you don't agree with the prompt, give us reasons why you don't want. And there were often very good and justifiable reasons. So the numbers here are still awful, but remember, so we started with people who are not meeting targets for control. So the targets were an A1C of less than 7, a blood pressure of less than 140/90, and an LDL cholesterol of 100. And only 7% people met that. And a very small number met that. At the end of the trial, it was a 2.5-fold difference. Even then, in absolute terms, very few people were still meeting it, and that's a reality. But it still increased the likelihood of meeting all 3 targets of care by about 2.5-fold, which was a huge impact if you see in terms of what we did. We didn't use fancy medicines. We didn't try anything new. We just created a process flow which was different. And this is just to say that the difference between the A1Cs, systolic blood pressure, and LDLs of those in whom the CDSS prompts were not accepted versus those in whom they were accepted, showing that those prompts were based on reasonably good scientific evidence, was a 0.5% A1C, was nearly 20 millimeters of mercury systolic, and a significantly similar number for LDL cholesterol. So it really, really made a lot of difference because it compelled the doctor to do something which they should be doing based on evidence-based guidelines. We showed very similar results at secondary care. And as I said, this is now what is going on in Punjab, which is one of our other provinces in the northern part of the country, which incorporates everything. So we start from frontline workers who are given a mobile phone to capture a community-based so that's a standard checklist which they're supposed to do. So instead of a paper checklist, it's on the mobile. That information directly feeds into the government NCD portal so that the auxiliary nurse midwife at the level of the subcenter can have a screening. The screening data is entered and is available to the primary care physician. So everybody knows what everybody should know. And it also identifies individuals who should have been referred for confirmatory diagnosis and treatment, who otherwise would have got lost in the system. They still get lost, but we now know which ones were supposed to be going, which is a significant improvement for what happened. Right. So the algorithms actually were reasonably simple. Initially, when we did it for tertiary care, we did fasting, glucose, and HbA1c, obviously systolic and diastolic pressures and LDL cholesterol. We also then realized that depending on the level of care you go to, an A1C is not always available, right? So you end up requiring. So we've now made a sort of a cafeteria choice of algorithms, and depending on whatever is available, it kicks off something and gives you some sort of response. So at least it's basically compelling the physician to think, even if they don't accept the prompt, they are being told, this is a problem. We think you should do this. even if you don't take on the specific advisory for medication, do what you want to, but do something, rather than say, okay, let's wait for another 3 months and see what's happened. So clinical inertia, which was referred to early in the morning, is also addressed to some extent by that. I'm going to sort of close down now by essentially saying that the biggest positive for us has been that the new version of the national program, which was launched in the country on the 17th of May, has finally decided to take all of this and make it available as part of an optional care model to the states. As I said, the states will decide what they want to do, but this has been, for us, a 12-year journey which has managed to get something which started in academia into a governmental policy. Hopefully, it'll have better care, better control, and impact. And it also will ensure that we're not looking at, diabetes separately, CKD separately, blood pressure separately, cholesterol separately, but a full story in it. And that's where I think I need to stop by essentially saying that we had a lot of the structures in place, but we were not using them properly, trying to innovatively use technology and software of different descriptions, assuring referral thresholds, which are also defined within the algorithms, ensuring referral linkages, facilitating referrals up and down, a whole suite of apps. And we're thinking more now of drug supply chain apps and patient-facing apps, and the clinical decision support software. So we're really trying to harness digital solutions with the hope that it'll make a difference. Whether it will or not, time will tell. Thank you so much.